I'm Dr. Linda Gray from Duke University Medical Center, and I would first off like to thank the Canadian Spinal CSF Leak organization for the opportunity to speak today. And I just wanted you to know that I am a member of the medical advisory team of the Canadian Spinal CSF Leak organization. I'm going to talk about intracranial hypotension, diagnosis and misdiagnosis, and I want to recognize three of my other colleagues, Peter Kranz, Timothy Ambrine, and Mike Malinzak, who also help take care of patients with this problem. I have absolutely no disclosures. My objectives today are to discuss the brain imaging findings of intracranial hypotension, misdiagnoses of intracranial hypotension, differential considerations for positional headaches, which can be a prominent feature of intracranial hypotension, the types of leaks to look for, and detection and percutaneous treatment of CSF leaks. So let's first talk about the brain imaging findings. There's a mnemonic SEEPS, which can help an individual think about the things to look for when you're thinking about the potential diagnosis of intracranial hypotension. And the first is subdural effusions, that's the S. Dural enhancement, that's E. Venous engorgement, second E. Pituitary swelling, loss of the prepontine cistern, and sagging brain. Now, sometimes the mammillary bodies will sit on top of the pons, which is another finding to look for. The iter, or the opening to the aqueduct, may be lower than the incidural line, and you may get crumpling of the quadrigeminal plate cistern. There's crowding at the foramen magnum, which can lead to a syrinx in the upper cervical spinal cord. Look at the floor of the third ventricle, and if it is downward sloping, that can be another sign of intracranial hypotension. So dural enhancement is a feature that we look for, and it should be smooth dural enhancement as opposed to nodular enhancement, which can be seen in this case in the setting of metastatic disease, or in this case in the setting of granulomatous processes such as sarcoid. Now, there can be misdiagnoses of intracranial hypotension for sure, and let's take a look at some of the reasons why that can happen and when it happens. So this was a 26-year-old patient who presented with a headache and was noted to have dural enhancement and a swollen pituitary gland. They missed the sagging brain in this case, but this was read out by a radiologist who is not a neuroradiologist, and he interpreted this as sarcoid as causing the dural enhancement and a pituitary tumor as causing the headaches. And so just be aware that not all radiologists are familiar with the diagnosis of intracranial hypotension or hypovolemia, and that not all neuroradiologists are going to be reading your MRI imaging studies. In this particular case, the patient was referred to neurosurgery at Duke. She got a biopsy of her pituitary gland, which was normal, and then she got sent down to radiology because her headache had worsened and they were thinking she might have a CSF leak at the base of skull. We recognized the findings, obviously, of intracranial hypotension, worked her up, and this was all of her imaging findings were due to a ruptured nerve root diverticula. Now, this 30-year-old patient was in Chicago, and she developed all of a sudden positional headaches when she was jogging on a treadmill. She became bedridden. Her family practice doctor admitted her to the hospital where she was seen by both neurology and neurosurgery and was told that she now had migraine headaches and she was just going to have to get used to it. The radiologist unfortunately missed the dural enhancement and the subdural effusions, so she got sent to us, and the etiology of her imaging findings was due to a ruptured nerve root diverticulum. So here is the normal thecal sac and the contrast outside the thecal sac, and this again was due to a ruptured nerve root diverticulum. So she didn't have migraines. She actually had a ruptured nerve root diverticulum, and she was not going to have to live with migraines for the rest of her life. So, is this intracranial hypotension, or is this just a Chiari malformation? This patient was brought to a headache conference that we have regularly, and the neurosurgeon brought it, and the patient was being considered for a Chiari decompression, and you can see that there are low-lying tonsils for sure here, but in addition to that, there's loss of the suprasellar cistern, probably flattening of the third ventricle, loss of the prepontine cistern, and the neurosurgeon failed to recognize the dural enhancement that was present. So all of these findings were not due to a Chiari malformation, but were rather due to a leak caused by a thoracic disc which had penetrated the thoracic spinal dura. So neurologists and neurosurgeons may also not be familiar with the imaging findings of intracranial hypotension or hypovolemia. So what is a Chiari? A Chiari is caudal protrusion of the tonsils or tonsillar ectopia that can be peg-shaped in appearance. Usually this is greater than 5 millimeters below a line drawn across the foramen magnum. And healthy adults usually or rarely have tonsillar ectopia that is greater than 3 millimeters. This can be associated with abnormal CSF flow, and even a syrinx in the spinal cord can be associated with it. And generally, this is due to a small posterior fossa. So how to evaluate for intracranial hypotension versus Chiari malformation? Well, in this particular case, if you look at both of these cases, they have tonsillar ectopia that is present. If you draw a line from the tuberculum sella to the confluence of veins, which is vein of Galen and straight sinus, this is the incisural line. And the iter, or the opening to the aqueduct, if it lies below this line, is something to think about in the setting of intracranial hypotension. With a Chiari malformation, you'll have a small posterior fossa. In addition, the iter, or opening to the aqueduct, should be at the line or above it. So look for that iter. Now, CSF flow studies can be helpful, and this is a patient preoperatively who has tonsillar ectopia and loss of flow behind the tonsils, as we're seeing here, and diminished flow behind the spinal cord in the upper cervical spine. Postoperatively, you can see that there now is improved flow behind those tonsils. So sometimes CSF flow studies might help, but in general, they'll probably be positive whether you have tonsillar ectopia due to SIH or Chiari malformation. So this question came up in this 20-year-old who had had 4 years of headaches that she rated at 8 out of 10. They were new daily persistent headaches at the back of her neck and at the back of her head and neck, and radiated into her shoulders. She had nausea, vomiting, sensitivity to light and smells, and blurred vision. And all of these symptoms improved with lying down. Her opening pressure was 22.5. So here is the line that goes from the tuberculum sella back to the confluence of veins back there. The iter lies right along that line. Here is her tonsillar ectopia, so she clearly has descented tonsils. And all we could find on myelogram was maybe a little leak off of the L4 nerve root. We patched this. There was it did not help her headaches at all. We put her on Dimox. Again, that was of no help. And so she actually underwent Chiari decompression. And here is our patient right here. And you can see that she had 11 millimeters of tonsillar ectopia, opening pressure of 22.5. And I want to compare that to two other patients here. This one had 9 millimeters of tonsillar ectopia with an opening pressure of 34.75, and this one had a 7.5 millimeters of tonsillar ectopia and an opening pressure of 41. Now, our first patient underwent a Chiari decompression and was headache-free. These other two also underwent Chiari decompressions. So the patient with the Chiari was headache-free. Both of these patients who had high opening pressures still had headaches. And this third one was on Dimox, 2,000 milligrams a day in addition to Topamax. So when you're looking at a Chiari and you're considering Chiari decompression, think about intracranial hypertension as well as intracranial hypotension. Should Chiari even be done in the setting of intracranial hypertension? 23% of patients with intracranial hypertension can have tonsillar ectopia, so also keep that in mind. Now, obviously, you can also see tonsillar ectopia in the setting of intracranial hypotension or volemia. So you're going to look for other signs that we've already discussed. The iter being below the incisural line, as we're seeing here, and loss of the suprasellar cistern, and loss of the prepontine cistern, mammillary body sitting on top of the pons. We took care of both of these patients they both had CSF leaks due to diverticuli, and one was due to a catheter placed for delivery, but we treated both of these leaks, and you can see that the brains actually became normal in appearance after appropriate treatment. Now, Chiari 1 can actually spontaneously regress, as in this patient right here who has clearly tonsillar ectopia, but over the course of 5 years, the tonsillar ectopia actually reduced. And maybe that was due to the fact that the posterior fossa actually enlarged. So maybe Chiaris don't have to be operated on right away, but you can just manage the patient for a while. This was a patient who had an acquired Chiari malformation over about a 7 to 8 month period. And here you can see, here they are in April, and by November, they've got tonsillar ectopia. In addition to that, they have dural enhancement. And all of this was due to a CSF leak caused, again, by a ruptured nerve diverticula. So in the setting of a tonsillar ectopia and Chiari malformation, I think we should always consider intracranial hypertension or hypotension before doing a Chiari decompression. And Chiari decompressions actually can have serious consequences. So this was a patient who was called a Chiari, and you can see they've got a syrinx. They also have mammillary bodies sitting on top of the pons and some downward sloping of the third ventricle, which was missed. They had a suboccipital decompression, and the patient herniated as a consequence of this suboccipital craniectomy and died. So really, Chiaris can be other than just routine procedures. So just keep that in mind. So rule out intracranial hypertension and intracranial hypotension before operating on a Chiari malformation. So the other feature that we can see with intracranial hypotension are subdural effusions. And here was a patient who developed collapsed actually at her daughter's wedding, and she was found to have, taken to the ED, was found to have bilateral subdural effusions. She only had a history of chiropractic manipulation and back pain. She got an MR scan of the brain demonstrating the bilateral effusions, even has some proteinaceous material that we can see here, dural enhancement, and clearly loss of the suprasellar cistern and sagging brain with loss of the prepontine cistern. Well, she got admitted to neurosurgery, and because of the subdural effusion, she got burr holes on 2 separate occasions, 8 days apart, which never helped the patient at all. She never improved. And after the family debated, and I unfortunately don't have time to go into the details of that, although it is interesting, they actually decided to transfer her to Duke. And her opening pressure when we started to evaluate her was 0. We did a myelogram. She had no obvious CSF leak. We didn't know about fistulas at the time, but she had some nerve root diverticuli, which we patched, and she completely resolved in 4 days. She became a normal patient, a normal person. She was able to drive again. People thought she'd never be able to do that. And you can see she went from a sagging brain to a normal brain here. And this is her normal imaging study 2 months later. This patient was 78 years old, and he developed severe headaches in May of this year. And he had a preceding event where he was hit by the boom of his sail. He's a big sailor in Lake Michigan. The headache actually extended from the back of his head up to the front of his head. It was greater on the right side than the left. He went to the ENT because of his facial pain that he was having. And the otolaryngologist said he had a perfect migraine headache and gave him literature on migraines. Well, his daughter happened to is an infectious disease doctor at Duke who's very busy right now with COVID. And she looked at his imaging studies and talked to some people, and they thought maybe he actually had intracranial hypotension. And you can see here he's got bilateral effusions, and he's got dural enhancement. So are these subdurals due to trauma? He was hit in the head by the sail. Well, we did a couple of myelograms, and we patched him, and he just was not really improving. As a matter of fact, after 2 blood patches, he developed more hemorrhage into the subdural effusions. And this is susceptibility-weighted imaging, or SWE, and this shows hemorrhage into these subdural effusions. And I really was thinking that maybe this patient just needed evacuation. So I talked to the neurosurgeons who actually said, no, this is not something that we're going to take care of. This is something that you're going to take care of. So We did a third myelogram, and thankfully this time we found the CSF venofistula. We patched him, and within 2 weeks, his subdural effusions started to diminish in size, and he became nearly asymptomatic. So he was 98% improved. So resist the temptation to operate when you have bilateral subdurals and really no history of trauma. And fistulas can be super hard to find, so just keep looking. This was a 28-year-old soccer player who developed severe positional headaches in his forehead, involved his eye, and he had ear pressure. Clearly, he's got intracranial hypotension. He headed a lot of balls while he was playing soccer and fell, I'm sure. And here is a small disc at the T12 level that is causing a ventral CSF leak that we're seeing right here. Now, this was treated. He was surgically treated, and this was repaired. One of the reasons why I bring up this case is it's very important to think about CSF leaks in the setting of headaches as a secondary cause of headaches, because if you miss this diagnosis, patients can actually get superficial siderosis as a consequence, and this is, you can't reverse this problem. So once you get it, you can develop all kinds of hearing problems and instability because of the layering of hemosiderin on the cerebellum. So this can be, this deposition is irreversible, and so really keeping this in mind is very important for the patients. Now, normal imaging does not exclude a CSF leak, and about 10% of patients may have no signs of a leak. And this was a 56-year-old sitting on our porch in the mountains of North Carolina who all of a sudden developed a 10 out of 10 headache when she was sitting or standing, but it went completely away when lying down. So classic kind of presentation. She's got a normal brain MRI. But what she did have, and what were causing her symptoms, was she had a CSF leak right here, which was due to this calcified disc in the thoracic spine, which had penetrated the dura. But she has a normal brain imaging study. This 37-year-old female was who was a neurology stroke fellow, had an abrupt onset of headache while she was attending a stroke meeting. And she had blurry vision, nausea, fatigue. She only had 2 to 4 hours of upright time. And when she laid down, it took 2 to 3 hours for the headaches to resolve. There is nothing here that would suggest a leak, normal imaging findings. But she had, again, a thoracic disc which had penetrated the dura, causing this CSF leak. So again, normal patient with a CSF leak. This 32-year-old had 7 years of headache, which had worsened in the last 3 years. Originally, the headaches were worse with straining, and then 3 years ago they improved, and then the headaches became positional. She was treated with migraine headaches and amitriptyline, treated like an atypical migraine, but the medications did not work. She has a normal-looking brain. You might argue that she has a partially empty cella. Well, she actually has a calcified disc which has penetrated the dura. So here she has a ventral CSF leak from a calcified disc, but negative brain MRI imaging. So realize it does not, normal imaging does not exclude a leak. And in the setting of new daily persistent headache or chronic migraine, think about a possible CSF leak. This 56-year-old, again, normal brain imaging study. She's had 21 years of headaches. She would run in the morning when she would feel the best, and she'd be in bed by 10 a.m. Her headache was holocephalic. She had nausea, sensitivity to light, noise, and smells. And it was 21 years ago when this all came on. It was felt to be hormonal, but no medications ever worked for her. And one important thing to note was that these symptoms began after the delivery of her last and third child. And she had an epidural catheter placed for that. Now, who would think that 21 years after this, that an epidural catheter could still be causing symptoms? We got sent to us, we worked her up. We did a myelogram. We didn't see anything. It would be really, it would be super unusual to see something 21 years out, but we did a circumferential patch here that went from L2-3 to L4-5, and she is now headache-free. I have one patient who had 35 years of headaches related to a CSF leak, and I patched a couple of nerve root diverticuli, and she was headache-free after 35 years. So even with long-term headaches, consider CSF pressure as a cause, and it does not, normal imaging does not exclude having intracranial hypotension or a CSF leak. So normal brain MRI, this is in a patient who has a history of idiopathic intracranial hypertension and papilledema and chronic headaches. Originally, she had opening pressures in the 30s. So she had a prior opening pressure of 31, but when we saw her, her opening pressure was 10.5. And if you look here, here is the thecal sac and the spinal cord in the center, and you're going to see contrast outside this thecal sac. And here we're going to see just a little bit lower here that she has contrast outside of here. It's extravasating out nerve root sleeves, as we're going to see. So here is extravasation of contrast coming out. And this is all at the thoracolumbar level. This is extravasation of contrast coming out nerve root sleeves right here. And this is a patient who actually had intracranial hypertension and blew out. So intracranial hypertension can present as a spontaneous CSF leak due to blowing out of the thecal sac. So again, normal MRI did not exclude a leak in this patient. So differential considerations for positional headaches, which are a common feature that we look for in patients with hypovolemia or hypotension. So here's Garfield, who feels like his body is rejecting him and he wants to lie down. And a lot of times patients will want to be supine, but sometimes they want to be in Trendelenburg even. And so some considerations for positional headaches should include, of course, low pressure or low volume syndromes, patients with high pressure or high volume syndromes, and cervicogenic causes can also be responsible for positional headaches. So let me give you some examples of this. This was a 15-year-old who I saw who developed headaches after she was bounced on a trampoline, and you bounce on the trampoline and then you go into the water, and she landed head first upside down in the water, and she developed immediately a headache of 8 to 9 out of 10. And her headache would improve with laying down. Now her opening pressure was 23, which is, high normal. She had a normal brain MRI. So in the first 6 months that I saw her, we did 10 lumbar punctures. Every time we would do a lumbar puncture and take off 20 cc's of fluid, she would be headache-free and she would be able to be upright. So her positional headache would improve entirely. It just wouldn't last, but with the combination of the LPs and putting her on some Diamox and other diuretics that we changed her to, she became headache-free from 2017 to 2020. And then in January of this year, she developed a headache again. Her pressures were in the same range, and we did 12 lumbar punctures between January and June, same effect. She would become, we'd pull off fluid, and she'd be asymptomatic, and she'd be able to be upright. Meds were not being effective this time. She had no venous narrowing at all. Ultimately, she went on to having a shunt, and she is now headache-free. Now, I don't encourage shunts. I hate shunts, as a matter of fact. But sometimes there is a setting for a shunt, and in this particular patient, she's doing quite well with the shunting. This 47-year-old, who is a pediatrician, took her kids to King's Dominion Amusement Park, and 4 days after coming back from there, she developed a terrible positional headache. She was seen by neurology, and they suggested that she had a CSF leak. So here is the roller coaster ride that she took at this King's Dominion Park. And I said, well, listen, while you're waiting to come and see me, why don't you get an MRI of your spine? And sure enough, she had an extruded disc at the C6-7 level there, and you can see the disc there. It was a soft disc. We did epidural injections and treated her with cervical traction over the next 8 months, and she is now headache-free and can be upright. Now, another cause for upright headaches besides just an acute disc can be chronic degenerative changes. In particular, look at the C1-2 junction, where patients who have arthritis at this level can actually have trouble turning their head in addition to positional headaches. And here is the normal C1-2 junction, and this is very arthritic on the left side. And the treatment that we do for this is just to inject that facet joint with some ropivacaine and steroids. And this patient, who's 61 years old, actually presented with positional headaches, and we just treat her every 6 to 8 months, and she has no positional headaches and is headache-free. So the types of leaks to look for ruptured nerve root diverticuli, which I've showed you, discs that can penetrate the dura, and then CSF venofistulas, and I'm going to show you a couple of those as well. Other things can cause it. There obviously are, unfortunately, iatrogenic causes, like catheter placements and needle placements and epidurals, but facet joints as well can actually erode the back of the dura and cause problems. So what do we do for detecting CSF leaks? Well, we get brain MRIs, obviously, with contrast, and we also will do, sometimes patients will come in with MRIs of their spine, which you can do and see if you see anything, but not see anything does not mean that the patient does not have a leak. You will not see a CSF venous fistula on an MR scan. We usually work up patients with our CT scanner, and we have a CT fluoroscopic suite with a monitor, and we do all of our patients in this room real time and do all of our interventions here. So let me just show you how we do these. This is a patient who is in the CT scanner, and we localize the spot for doing the lumbar puncture as we've marked here. We use a 24 gauge Gertie Marks needle, which is a blunt tip side hole needle, and you have about a 1 in 1,000 chance of a post-LP headache with this needle. The other thing it does is it does not contaminate your field with contrast getting outside of the thecal sac. So you have very little contrast that leaks out with this needle. We also use this compass manometer, which is a digital manometer, in order to get our pressures. And this 24 gauge needle is bored out, so it's 22 gauge on the inside. So how do you we put in the contrast, how do you get the contrast to move when you have a patient on a table that does not tilt? Well, you can do some modified yoga maneuvers, and you can just have the patient do a pelvic lift, and the contrast will run right down. And you can also put the patient in a kind of a position like this with their head down and their hips up, and the contrast will run down into the base of skull, so you can even do a cisternogram. We do the patients, scan the patients then prone on the table at 0.5 and then render, or at 2.5s and then render them at 0.5 to 0.625. And everyone is scanned prone or in the lateral decubitus position for problem solving. If you scan the patient on their back, most of the time the leaks are not on the back. If they are, you might want to do supine imaging, but most of the time the leaks are coming from nerve roots or ventrally, and you want to scan the patient in a prone position and then get sagittal and coronal reformats. For problem solving, we may put the patient in this position here and do a dynamic scan, or lateral decubitus to look for nerve root leaks from nerve root diverticuli or CSF venofistulas. As I said, we put the needle use a Gertie Marks needle. It's in the center of the canal. It goes through an introducer because it will not penetrate the skin otherwise. We want to get it in the center of the thecal sac. We usually inject 10 cc's of Elliott's B solution. You could use preservative-free saline in order to boost the pressure in the sac, and then we inject Isobu 300M. And we do a total myelogram then. And here is a total myelogram right here. And in this particular case, this patient has contrast leaking outside of the thecal sac, and the thecal sac is in the center. So what do you do when you have contrast which is distributed so diffusely throughout the epidural space? Well, then we have to do some problem solving. And in this case, we put the patient in a left lateral decubitus position first, and then we scan the patient in this left lateral decubitus position. There's contrast outside the sac in the epidural space, but it's not contaminating our imaging. And as we went along here, we could see that there was a large nerve root diverticula, which was located right here. And this is a ruptured nerve root diverticulum, which had caused all of that extrathecal contrast. Sometimes when we have ventral leaks, we have to do very fast scanning, particularly in the upper thoracic spine. And we'll put the needle in and run in the contrast and then scan rapidly up in the upper thoracic spine, as we're seeing that image there. Here is a patient who had a big ventral CSF leak that we're seeing here and had two discs, one smaller, one larger. And we did rapid scanning in the upper thoracic spine, and here is the leak that you can see right here on the axial images and the sagittal reformatted images, and this was actually emanating from the smaller disc as opposed to the larger disc. We found that inspiration enhances our ability to detect some leaks, in particular CSF fistulas. Here's a patient who's prone and then in a lateral decubitus position, and you can see kind of an elongated nerve root sleeve right there. Maybe you'd wonder if that nerve root was suspicious, but with inspiration, we could see that that contrast was filling that elongated nerve root sleeve and then filling the paraspinous vein right here. And so this inspiration with lateral decubitus imaging helped us to detect that leak. So you have to do some problem solving sometimes when you're looking for these very subtle abnormalities. This is a patient who had an irregular nerve root sleeve, and in the lateral decubitus position, we discovered that this was actually a CSF venofistula filling the paraspinous vein and then the azygos vein. And the way we treat these patients is we do targeted CT fluoroscopic guided patching. And I'm just going to show you how this works. We put a needle, in this case, down to that transforaminal region, inject contrast first, and then follow that with fibrin glue adjacent to the dura, and then back that up with a little bit of blood. I think you may need the platelets in the blood in order to actually get a really good patch. This is a 29-year-old who presented to the ED with meningitis, and in that workup got a lumbar puncture. So she was admitted to the hospital. She resolved her aseptic meningitis or viral meningitis, but she had a positional headache after that. And it was due to the fact that when she was in the emergency department, they actually went all the way through the thecal sac, probably into the disc, and she had a ventral CSF leak as a consequence of the lumbar patch. So her prior lumbar patches to treat her positional headache, which were dorsal in location, were not going to treat this ventral patch. But we can do ventral patches through a transforaminal approach, and this is what we did here. In order to actually, so here is the patch right here located ventrally in the spinal canal, and this resolved her positional headache. This was a 21-year-old who actually presented with acute intracranial hypotension after 4 attempts of a lumbar epidural catheter placement. And here you can see all the findings of intracranial hypotension with sagging and dilatation of the venous sinus and dural enhancement. When she came down to us, she was intubated, and she was intubated and actually obtunded. Through this transforaminal approach, we could get a circumferential patch here, and 2 days later, her brain normalized and she left the hospital with her baby. So the takeaway points that I want to give to you from all of this that I've talked about today is when thinking about whether to operate on a Chiari, why not exclude high and low pressure syndromes first before the operation? Normal imaging does not exclude a treatable cause of headache, so think about high pressure and low pressure as a treatable cause of headache. Differential considerations for positional headaches include intracranial hypotension and hypertension, as well as cervicogenic causes. Subdurals, in the absence of trauma, I think you should exclude a low pressure syndrome first before draining those subdurals. And what should you look for in terms of CSF leaks? Well, look for ruptured diverticuli, discs, fistulas, but realize there are other causes of leaks as well, such as facets, and then obviously, unfortunately, iatrogenic causes as well. And then we use CT guidance for detecting and treating our leaks. And with that, I want to thank you for the invitation to speak today, and I look forward to taking any of your questions.